So this is going to be a summary of the first week of a motor control and learning class. Um, I'm basically going to go over the key points we've talked about in the last Monday and Wednesday. So initially, I started talking about the basic forms of long-term memory, and we can see the two basic forms, an implicit and explicit. Implicit is where you acquire the ability to do a motor skill without actually being cognitively aware of you of that learning itself. Explicit is where the therapist gives you instructions or gives the patient instructions, feedback, etc., and they are aware of how they're doing the skill and how to improve the skill through your feedback. We rarely use, well, not rarely, but these non-associative, associative learning. Habituation essentially is where the patient is continually exposed to that stimulus, and after a while they get used to it, and it's not such a it doesn't provoke, what's not the word I'm looking for, it's they get used to it and it doesn't affect them as much. So habituation, for example, is used in vestibular rehab when you have vestibular symptoms which are not quite unpleasant. You deliberately expose, you force the patient to um, be exposed to those unpleasant stimuli, that dizziness, that nausea, that vertigo, etc., and the brain learns to habituate to them, and they're as not as effective in producing a bad response. Then sensitization is when people more time they're exposed to that stimuli, the worse it gets, and that's we don't really use that in physical therapy. Um, Classical conditioning and operant conditioning, I don't think really we use classical conditioning at all in physical therapy. That's Pavlov's dog salivating experiment. Operant conditioning is Skinner's work, where you reward good responses and you punish bad responses. We certainly do that. We reward good responses in a patient by giving them feedback, giving them praise, and they tend to do that response more because of they're seeking that reward, they're seeking that praise from a therapist. Most of the time, though, perhaps we're using these procedural learning and these declarative learning over here in our treatment. Procedural learning is where somebody learns the procedures, the processes of doing the skill without actually being cognitively aware they're doing it. So that's part of this implicit category. So what we want to do as therapists is structure an environment and the learning situation that patient can gradually learn that skill, perhaps without them even knowing they're doing it. Declarative situation is where we actually tell them how to do it and help them and give them feedback and instructions to improve their performance. So those are the basic types of learning there are. We will be looking at more procedural and particularly declarative knowledge or explicit ways of teaching patients in this course. What is motor learning? Well, it's a set of unobservable processes that leads to a relatively permanent change in the capability for responding as a result of practical experience. The key point here is unobservable. It's occurring in the central nervous system somewhere. So we have to infer infer learning that's taken place by a patient's change in performance, the change in behavior. We think learning has occurred because of this. We think learning hasn't occurred because this is the behavior they're exhibiting. We have to have it relatively permanent for it to be learned. They have to have a retention test. You have to be able to do it when at a later date when the therapy is not helping them. So during practice, so when we're looking at, because it's unobservable processes, we have to look at various types of performance to infer learning has taken place. One type of performance we look at is practice performance. This is during treatment. So we're helping, we're giving tips, we're giving feedback, we're giving instructions during practice, and that can help people perform better. This is treatment or practice or acquisition. This would be more is the better, like how far you can walk in a certain amount of time. This would be errors. Over here gets less with practice, time decreases with practice. And what we want to do is obviously improve performance during practice, but that's not as important as how they perform at a retention test. We cannot tell which of these groups here, the red or the blue, is actually going to learn the best. Even though the red is performing better during practice or during treatment, we cannot say they've learned more until we do a retention test at a later date without any feedback, without any instructions, whatever it is. And you can see here in the retention test, the red group have learned more, because this is the indication of learning here. This is retention, not practice performance. So this is what we have to look at. You'd hope the red group would do better than the blue group because they were doing better in practice, but that's not always the case. The red group might be doing worse in retention because of what you did here to improve them. For example, too much feedback, they become reliant on that feedback. They don't learn it themselves. So when you withdraw that feedback in a retention test, that group can do relatively poorly. Okay, so this is learning. This is some basic concepts of motor learning, which we'll be spending the second half of the semester talking about. We'll get back to these graphs in the second half of the semester. The first half semester is going to be talking about motor control, and this is my way of thinking about motor control. We need to know how a patient, how a person, how an animal, whatever you're looking at, what are the control processes underlying that movement we see? What is driving behavior? How is that movement, that motor coordination, that behavior, that gait, whatever it is, how is that being controlled? And what is driving that behavior? It's no good just to know how to treat it from a book. We need to know what drives it. Therefore, we can design our own treatment. Because I believe that the way somebody moves should, or the process involved in producing movement, we need to be aware of those, because the way we assess and treat a patient will be biased by the theoretical framework you believe in. Just like, remember the car, the two cars example, the electric car and the gas-powered car. Okay, the only way to treat or diagnose and treat those two cars effectively is to understand what drives the motor. Is it electricity or is it gas? So it's no good, trying to treat a car with a dead battery by filling it with gas. We need to know how those machines, how those humans move in order to be able to effectively assess and treat that problem we see, whether it be a dead battery or bad gait, whatever. And for example, we talked about the cerebral kids with spastic diplegia walking on their tiptoes with spastic gastrocnemius. There are two different ways of thinking about why those kids have that spastic gastrocs, and that gives rise to two different ways of treating that kid with spastic gastrocs. And we're going to talk about that in more detail later on. So the first half semester is going to be looking at these theoretical models of how we can describe, how we can explain human movement. All right, so any theory model that's trying to explain how people move, one of the things you have to be able to explain is how people can move with all these degrees of freedom. Remember, degrees of freedom are things that are free to vary. They're not set in stone. In terms of the shoulder, we talked about, we have biomechanical degrees of freedom of rotation, external, internal. We have abduction, adduction. We have flexion, extension. So every time I move my arm, those 3 degrees of freedom, those biomechanical degrees have to be controlled. They're controlled by muscles. Lots of muscles around the scapula, lots of muscles controlling the arm. How is that controlled? Who is controlling all those dozens of muscles? within the muscles themselves, there are thousands of motor units controlled by untold numbers of alpha motor neurons and gamma motor neurons. Think about the whole body as you're running and jumping around. There are millions and millions and millions of signals being sent down these alpha motor neurons and the gamma motor neurons, the muscle spindles, every second of that movement. So we're trying to figure out, how is that possible? What is a thing? What is a process by which all those millions and millions and millions of signals can be coordinated, can be controlled to produce a beautiful whatever, pole vault or jump or hop or skip, whatever. Those have to be coordinated, have to be controlled to allow that movement to occur. And this control of all those degrees of freedom is made more difficult in our neurologically involved patients, because then there was some damage to some part of the nervous system, which really makes this degrees of freedom problem even harder. And I think that some of the solutions patients present with, some of the symptoms you'll see of a disease is their attempt to solve this degrees of freedom problem. You can also think of degrees of freedom problem being the number of ways in which you can move to pick up an object or throw an object, or how would you reach for a door handle. There's so many different ways, in almost infinite sort of trajectories you could use with your hand to reach an object. How does the nervous system, or what is it in the nervous system that decides how to move your hand to pick up something? So that's a major issue for any theory of motor control. And so then we started looking at attempts at solving that degrees of freedom problem. And these are the chronologically ordered situation here. That the reflex model was the first model proposed, hierarchical or information processing was second, and then more recently, the dynamic systems model has tried to explain how those degrees of freedom are controlled. And if we look at the very first one of those, the reflex or peripheral model, this was sort of one of the key founders of this idea was Charles Sherrington at Liverpool, where he looked at a cat with a midbrain cut. So the brain was severed from the rest of the body, the nervous system. So the brain cannot control the legs or any part of the body, and the feedback from the legs and body cannot get to the brain. So essentially, it's taking the brain out of the system. So what can the body do without a brain? Do we need a higher center, the cerebrum, to control the legs in, for example, walking? So we had these cats, midbrain cut, supported them on a treadmill, lowering them down on the treadmill, and the treadmill started to move. And lo and behold, the cat started to walk. The cat then, as the treadmill was sped up, started to run. They did lots of other things. They put a bit of athletic tape on the cat's paw, and the cat would shake it in swing phase, but not in stance phase. So a phase-dependent reflex or reaction was coordinated with the gait somehow, again, with no brain involvement. You put the cat on two treadmills side by side, the right legs on one side, on one treadmill, left legs on another, and you drive those two treadmills at different speeds. The left legs would walk on a slow moving treadmill. The right legs would run on a fast moving treadmill. Obviously, the cat's never done that ever before, but he's still managing to do that, even though he has no intact brain that's talking to his legs or the rest of his body. You tape one of the cat's legs to his chest, and the cat can walk and run with three legs without ever having done that before. Again, no brain involved. So Sherrington came up with a notion of how this is possible. How can you control movement and gait, for example? How could this cat walk without a intact brain talking to his legs? So he came up with this idea of what's known as response chain hypothesis, where the movement of one part of the skill, the leg, the elbow, the arm, whatever, provided feedback from the environment. So moving my leg produced feedback, like I felt my heel hit the ground, whatever. That feedback then initiated the second part of the movement, which then gave feedback to initiate the third part of the movement. And with a cyclical activity like gait, this thing would go round and round and round as a cat walks. So this is a peripheral model or reflex model, because feedback, the peripheral feedback, peripheral sensation from the environment drives the action. The feedback is the controlling signal that makes the cat or the person move, whatever. And without this feedback, then without sensation from the environment, movement is not possible with a reflex driven model or a response chaining hypothesis. All right, so there are, if you believe in this model that we are reflex driven animals, for clinical implications, we better know our reflexes. And there's tons of different reflexes out there, low-level reflexes that can influence our movement. So as clinicians, we test many times, particularly in pediatrics, for example, and also in patients with stroke or spinal cord injury, we test these reflexes for diagnosis and for treatment. So from this perspective, we will try to inhibit inappropriate reflexes that have emerged as a result of his neurological lesion. We might use some reflexes to facilitate certain movements. We might use the asymmetric tonic neck reflex to facilitate reaching, for example, and we'll talk about that one more later. Anyway, so reflexes from some clinicians are very, very important because they believe reflex is essentially a building block of movement. So we need to know those building blocks. Limitations to a pure reflex model, then we have such a thing as supraspinal control. In normal situations, intact animals, intact cats do not have a midbrain cut, and the brain can influence lower levels. So we can overcome flex withdrawal reflex. I can pick up a hot plate. I can stand on a thumbtack, whatever. Even though it's painful, I can do it if I have a brain to tell my body to overcome that normal reflex, withdrawal reflex from that painful stimulus. Lou Nash did some interesting experiments that sort of showed this supraspinal control too. He had people stand on platforms on the floor, and the platform would go back under their feet unexpectedly. That would cause dorsiflexion of the ankle and therefore stretch of the gastroc. And then you'd find the reflex would come on and pull them back up. In this situation, the platform would tilt upwards underneath their feet, which would also cause stretch of the gastroc because you're causing dorsiflexion. So what happens in this situation is very different. In the first situation, when the reflex is good for you, you can see the EMG comes on earlier in the skill or in the movement, and the sway is dropped because as a result of that. So in essence, what's happening with practice, this reflex, this stretch reflex is facilitated, is sped up, and allows the person to stand up quicker, and with less sway. More dramatically, where the reflex is bad for you, when the platform is tilted upwards, you stretch your gastroc, causes stretch reflex, and that would normally push the person backwards with plantar flexion at 4 on their butt. But as you can see in here, after 4 trials, that reflex, the EMG, disappears. And the sway drops to almost nothing. So in other words, with a little bit of practice, the brain has basically told this reflex to stop. It turns off this lower level reflex, which is occurring at the spinal cord. So descending pathways are turning off this reflex at the spinal cord, so the person does not fall on their butt. Again, this is supraspinal control, high center control. We are not obliged to follow our low level reflex in many situations. The stretch reflex of the kneecap, you can't stop. And we talk about the Jurassic maneuver as a way in which you actually facilitate that by clenching your teeth and clenching your fists. So, but most reflexes, most of these very low level reflexes, primitive reflexes, we can overcome with a supraspinal, with a brain control. Now, what happens if you lose that control from the brain? If this person was a patient who had a stroke or a spinal cord injury, you cannot control, turn off this reflex. If you did this little experiment with a person with a stroke, for example, they might not have the ability to turn off that reflex, and therefore they would fall on their butt, showing again the importance of supraspinal control. Another experiment showing limitations to a pure reflex model is deafferentation studies. Torb's work, where he cut the dorsal roots of a monkey on his brachial plexus, and therefore the monkey could not feel for example, his right arm. So when you do that to a monkey, the monkey will basically not use the right arm anymore and use the left arm for all his everyday activities. However, if you restrain the good arm, the left arm in this situation, with a sling or whatever, the monkey then starts using his bad arm to do his activities of daily living. It's not as skillful as his good arm, but it does work. It can move, it can achieve some function, basically showing that you do not need sensory feedback to move the limb, as a reflex model would say. So this is the whole basis of the forced use. It used to be called, now it's called constraint-induced movement therapy, where you constrain the good arm, the non-stroke side of a patient with stroke, for example. You put an oven mitten over their good hand, and you force them, you constrain them to use their weaker side, their affected side, the side that was affected by the stroke. And what happens with a lot of time and intense practice, that bad hand, bad arm, whatever, improves in function. There's plasticity in the brain, and the brain learns to reacquire function within that hemi side. Constraint-induced therapy is a quite powerful technique, and it's quite widely used at the moment. And I'd hope so anyway, because it has been shown to be quite effective in improving the function of limbs that have been affected by a stroke, for example. Paul and Busy also looked at the deafferentation study, and it's the last thing we talked about. They got a monkey like this who learned to point at various lights when they came on. This board here prevented him seeing where the arm was, and therefore they were using proprioception to get to each of these lights to get their reward. The monkey then was deafferentated, and he had his dorsal roots cut, so he could not feel his right arm. And then they flashed on a light, and lo and behold, the monkey could point to that light quite accurately without any proprioception coming from the arm. So there's something the monkey learned during training that is allowing the monkey to point to the light without any sensation of the arm. And we finished off by talking about various things, various conditions that the monkey could still point to the light. And we're trying to figure out now exactly what is the control mechanism for the monkey being able to point to the light in many different situations. And we're going to talk about that next class.